my dear friends and my dear colleagues, I would like to introduce you with an amazing cardiologist who works in Boston in United States of America. This good friend of mine, Henry Hahn, and actually one of the reasons why we really wanted to interview Henry is his recent paper on muffled. So Henry, can you briefly tell about a little bit about you, please?
Yeah, so first of all, thanks for having me. So yeah, my name is Hanalton, aka Henry Han. So most of my colleagues could recognize me as a Henry Han. So yeah, so I am currently practicing in the Department of Health, so, and also the MD program research specialist. And yeah, so the recently we have to publish the interesting review paper is like for connecting the three organs, so heart, liver, and pancreas. So this is I believe to join connecting to the different, the specialty to, combat the deadly diseases now is very prevalent in, across the world, like the heart failure, focusing on the heart health. So yeah, so happy to discuss with you, Amina. Yes.
So one of my first question is somehow related to heart failure also. So do you think cardiometabolic phenotype of a heart failure, so I mean, in majority cases, we were talking about heart failure with preserved ejection fraction, is a distinct phenotype, or maybe it's independent endotype of the disease? And also related to that, what is fundamentally changes in our understanding of the condition when each of these approaches is applied?
Yeah, that's a great question. Yeah, so it's like the term cardiometabolic, the heart paths refer to biologically defined mechanism. Is driven by the dietary nutrient excess, your visceral adiposity, and a cardiac the lipid overload, like as well as the systematic inflammation. That has been the most clearly established, in our experimental model. So, if you said about the phenotype, so it requires the reproducible clinical criteria. So which, cardiometabolic heart path currently lack in practice. So I would say that, cardiometabolic heart path is best understood title as an independent endotype rather than distinct clinical phenotype. When this framework is applied, as of now, our understanding of the heart path, the shift from the heterogeneous clinical symptom to mechanistically stratified disease in which you can say that the corresponding clinical entity is the more accurately described the adiposity related heart path, just the fiber visceral fat accumulation, right? This is down the emergent hypothesis and how it's relating to the elevated filling pressure. So I would say this distinction is clarified, our, the understanding of the pathophysiology is explaining the differential treatment response, and that's supposed to targeting therapy and our, understanding of the biological rather than clinical clustering. Yeah.
So do you think that we can actually, I mean, consider heart failure with preserved ejection fraction not like just a cardiology disease, but maybe a multi-organ or metabolic, I mean, exact metabolic disease? How it's better to define or to distinguish?
Sure. Yes, exactly. Yes, heart valve is increasingly understanding of, the systematic inflammatory metabolic disorder, right? So it's a different cardiovascular manifestation. The rather than we define it as a disease combined to the myocardium, it's not just only for the heart issue. We have a several underlying factor that contribute to the filling pressure and congestion in the heart valve. The number evidence also show the most patients have the comorbidities, right? Including obesity, diabetes, and hypertension, CKD and agents, right? Right? So these all drive a chronic low-grade inflammation that leads to, endothelial dysfunction and as well as, metabolic dysregulation. Yeah.
Yeah. Well, now let's go to the liver disease, to hepatopathy. So when it can be developed from hepatopathy to cardiac cirrhosis, I mean, and what stage, what point is, and do you think it's reversible or not?
That's a great question. Of course, yes. When we talk about, the congested hepatopathy, it's like, the early congested hepatopathy is a form of largest reversible, I believe it. So with, effectively, unloading of the right sided pressure right? So it is increasingly linked to the heart path because the heart paths commonly feature with diastolic stiffness. It's that some our patient have a pulmonary hypertension, RV dysfunction. So in that point of view, in our recent review, we discussed about the congested hepatopathy as a early the potentially reversible states characterized by sinusitis dilatation, so from the hepatologist point of view, just central lobular congestion, So there's a like these are driven by the elevated RA pressure and the hepatovenous pressure. So let's say so clinically, so congested hepatopathy is reflected hemodynamic congestion rather than intrinsic liver disease. Well, so and it occurs in both heart path and half rep. The earlier data showed is that this, is like the hepatopathy is the form of the half rep, but now the particular association of the heart path duty is prosperity of the chronic venous congestion.
Okay. So, I mean, this is very interesting because, I mean, we are talking something like about boundaryless, but one of the thing is when, for your opinion, in your opinion, when muffled can play a role between, I mean, in distinguishing three different organs, heart, liver, and pancreas.
Well, yeah, it acts as the central amplifier for the liver, heart, and as well as the pancreas inflammatory axis, because now we are focusing on the inflammatory pathway. We have a different mechanism of the cardiorenal metabolic pathway, but sometimes we are forgetting about how inflammatory process we are going to intervene. So it's the kind of like, systemic lower inflammatory to metabolic inflexibility that leads to the pro-fibrotic disease. So in our review, that's what we discussed and highlighted about this steroids and inflamed liver disease that releases pro-inflammatory cytokines and hepatokines, as well as other oxidative stress mediator that promote the endothelial dysfunction. That we might have been awareness of or the recent the Dr. Milton Parker, is that he hypothesized about the adipokines, right? Is adipose tissue leads to dysfunctional adipose, the secretion of the inflammatory adipokines, it act for instance, it's like the leptin, so lecithin, so that suppress the protective one of the adiponectin. So in parallel, there's found of the metabolic associated, dysfunction associated liver steroid disease is tightly linked to visceral and as well as the epicardial adiposity. Which shifted, adipokines balance toward the pro-inflammatory and pro-fibrotic problem. So I would say that rather than acting and isolate this organ, this dysfunction in one organ can trigger or exacerbate, the pathology in other, the organs, the via systematic inflammations, endothelial dysfunction, and neurohormonal activation, as well as the microvascular injury. So I believe this framework helps explaining why the patient in heart failure often have the worst outcome when inflammatory and metabolic stress problem occurs.
Thank you very much for answering this question. I think it's very important. And, recently here, we're also trying to, to cover these topics. And that's why we also decided to talk about that, to discuss about that with hepatologists, with gastroenterologists. I mean, in February 25 to 26, we are trying to cover muffled liver disease and also heart disease. And we will really focusing on that. But from cardiologist perspective, because we are cardiologists, I mean, this next week, 11 to 13 of February, we would like to discuss it on in point of view from perspective of cardiology. So we still will somehow cover hepatopathy, but majority of the situation and majority of the lectures will cover it actually a heart disease involving different organs. So I would really like you to be part of this discussion, especially that will be in the end of February. But I mean, this is amazing that, we really don't have any borders to discuss a very important topics. And it's great to have you here. And it's also one of the most important thing. We will publish soon a very nice statement that is actually cover heart failure and liver. Right, Henry?
Well, yes, yeah, we are working on it. Yes, great. Yeah, thanks.